Gemma Deans, Case Study 1 by Chris and Harry. Gemma Deans, a young female, has presented to her local podiatrist with a painful area around her big toe. Gemma has seen this podiatrist a number of times with a history of treatment for Holomadurum and has also been previously treated for tinea pedis, a fungal infection, trichophyton rubin being the causative agent. A sample is taken from around the nail for analysis, but first we must understand the symptoms Gemma is presenting with. In the subjective assessment of Gemma's toe, she is presented with local pain just on her right toe, meaning the infection occurring at Gemma's toe is currently acute. Local acute increases in temperature, edematous, and erythematous presence on the right distal phalanx of the hallux, with a more intense purple eye presentation proximal to the sulcus on the medial side of the great toe, as well as tenderness near the medial nail fold. There is no distinct, well-demarcated border of erythema between the affected and unaffected skin. Due to the presentation of this infection, there is a possibility that it could have spread to the subcutaneous tissue. Gemma is not presented with these symptoms on other parts of the body or has pyrexia, eliminating the current risk of the presence of a current systemic infection. Although if this infection goes untreated, there is a possibility of this acute infection progressing systemically. Hyperkeratosis is presented on the medial margin of the nail, indicating an area of pressure or consistent trauma. There also seems to be presentation of purulent exudate along the medial nail margin beneath the hyperkeratotic tissue. The presence of a true abscess does not seem evident. Due to the history of previous treatment of tinea pedis and a possibility of recurrence of the fungal infection, this can cause potential trauma to the skin, creating a portal of entry for opportunistic pathogens. An establishment of possible primary infection can also provide adhesions for potential opportunistic lesions, increasing the probability of a secondary infection. This is done through symptoms of tinea pedis that is generally pruritic, macerated skin, scaly lesions, and typically associated with hyperhidrosis, creating an environment that can quite easily cause an opening for pathogens to inoculate the host and infect the tissue and thrive. In the photo of the affected right hallux has led me to a possible indication that this is a bacterial infection secondary to the tinea pedis. There are two pathologies that are under further investigation, my initial diagnosis being paronychia, a bacterial infection secondary to the tinea pedis infection. As seen, this infection is present in the proximal medial nail fold and sulcus. This infection can occur for a variety of reasons. In Gemma's presentation, I have suspicions that it has occurred due to possible trauma induced by symptoms of the tinea pedis infection. This previous fungal infection had the potential to have disrupted the protective barrier on the skin, providing a portal of entry to allow the inoculation of bacteria to the predisposed area, allowing colonization and leading to infection. The infection seems to have established itself alongside the nail margin, specifically on the medial side of the nail, a common site for paronychia infections. This alongside Gemma's other symptoms such as localized pain, warmth, erythema with poorly demarcated borders, and a more intense purple coloring near the medial nail margin, edema, and the buildup of purulent exudate beneath the skin in this same area. There is potential of the presence of an abscess, although there does not seem to be a true abscess visible. Gemma's background information, subjective and visual assessments have guided my educational diagnosis to be an acute paronychia bacterial infection. Commonly, the causative agent of paronychia tend to involve Staphylococcus aureus or streptococci, specifically strep pyogenes. A differential diagnosis is a localized mild cellulitis bacterial infection, which is also a common secondary infection to tinea pedis. Although this pathology usually affects a larger surface area of the feet and lower limb, in Gemma's presentation, it is within question that it is presenting on such a small surface area. Cellulitis is a very swift-spreading skin infection spreading to the subcutaneous layer, affecting various soft tissue structures like muscles and tendons. Common presentations with cellulitis are edema, acute and localized pain, erythema with poorly demarcated borders between affected and unaffected skin, as well as intense areas of red/purple erythema, although rarely produces a buildup of purulent exudate beneath the skin like it has in Gemma's pathology. It has similar causative agents to paronychia like Staphylococcus aureus or group A streptococci such as strep pyogenes. For example, we performed 5 tests to help eliminate various pathogen involvement and determine the causative agent of Gemma's paronychia infection. The first test was a microscopic analysis performing a differential staining, also known as gram staining. By identifying the differences in the cell wall, this helps to differentiate between gram-positive and gram-negative bacteria, as well as the shape and the morphology of the bacteria and its colonies. Gram-positive and gram-negative bacteria have distinct differences in their cell wall structure, in particular the thickness of their peptidoglycan layer. This is an important factor in the gram staining process, as the crystal violet and the iodine act in combination, creating a violet crystal iodine complex, making it hard to remove from the cell wall, specifically the peptidoglycan layer. Once the alcohol is applied, dehydrating the peptidoglycan layer, and due to the thickness of the layer and the gram-positive bacteria during this dehydration process, it will hold the stain of the crystal violet iodine complex. Whereas degradation of the peptidoglycan layer occurs in the cell wall of the gram-negative cells, thus the compound will not hold, decolorizing the gram-negative microbes. To ensure we are able to identify if gram-negative bacteria are present, we apply a saffron red stain in the gram-negative cell walls to ensure visibility under the microscope. Due to this process, we were able to identify the causative agent present, which was a gram-positive bacteriococci arranged in a chain-like formation. Staph aureus is a common causative agent in paronychia and cellulitis. We wanted to confirm or eliminate the presence of this species. We placed the bacteria on an MSA agar to see if growth would occur. There was nil growth and the agar was pink, meaning there was no acid produced to react with the mannitol for fermentation. This suggests Staph aureus is not present, although it does not distinguish if a Staph species is present or not, to which we then proceeded with our next phase of testing. The catalase test differentiates between staph, which are catalase positive bacteria, and a strep, catalase negative bacteria. The bacterial colony in the glass slide was mixed with a drop of hydrogen peroxide. This test is looking for the presence of the catalase enzyme, which is present in most aerobic microorganisms and non-existent in most anaerobes. The presence of this enzyme breaks down hydrogen peroxide into hydrogen and water, giving a bubble-like appearance in the liquid on the glass slide. A catalase test came up with a negative result, suggesting there was no existence of a staph organism or an aerobic organism, with our suspicions turned towards a possible strep or anaerobic causative agent. Catalase test gave us an insight on the presence of streptococci is likely. We wanted to confirm what kind of streptococci was present, so we exposed the bacteria to a horse blood agar. As strep are classified under hemolytic reactions with blood. This particular organism had the presence of hemolysin enzymes due to having a complete clearing zone, meaning it's a beta hemolytic streptococci. This reaction is commonly characterized by pyogenic hemolytic streps, although more specifically strep pyogenes, being under suspicion due to its involvement being the common causative agent of both paronychia and cellulitis. Differentiating strep pyogenes from the other beta hemolytic streptococci, we tested the antibacterial sensitivity of the microbe to bacitracin. The reason bacitracin was utilized as strep pyogenes is differentiated from the other beta hemolytic streptococci due to its increased sensitivity to bacitracin. This was seen in the agar plate, a zone of inhibition surrounding the antibiotic disc indicating the microorganism's susceptibility to the drug. The process of microscopic and macroscopic diagnostic tests allowed us to eliminate factors of other causative microbes and specifically confirm reactive factors of the microbe under suspicion. The causative agent of the paronychia infection being Streptococcus pyogenes, a facultative anaerobe beta hemolytic gram-positive cocci which is arranged in chains.
Additional diagnostic tests. Additional tests can be completed in order to further determine the specific nature of the species of the virus. Two additional diagnostic tests can be performed, including the Lancefield antigen determination test and the PYR test. Within the Lancefield antigen determination test, this test looks to identify the specific species of viruses within the beta hemolytic streptococci through determining the presence of Lancefield antigens found within the streptococci surfaces, demonstrated by antibodies. Within the test, once a group of cells from the investigative virus is taken from the agar and placed on a testing strip, the specific antigen from the grouping of A, B, C, F, or G will be added to the cells. When clumping of the cells of a visible positive reaction in the specific antigen is made, thus proving that said virus has the presence of the A antigen, consistent with Streptococcus pyogenes. This test can be helpful, as Streptococcus pyogenes will demonstrate a presence of Lancefield antigen A, assisting in identifying the specific species. However, the presence of Lancefield antigen A is not limited only to Streptococcus pyogenes. Because this does not give us a 100% classification to the virus, to species of virus, we can use the Lancefield antigen determination with the PYR test to come to a more sound conclusion. Within the PYR test, it is used specifically to determine Streptococcus pyogenes from other beta hemolytic streptococci by testing for the presence of the enzyme pyrrolidolin aminopeptide. This specific enzyme hydrolyzes the L-pyrrolidyl beta nephylamide, PYR, to beta nephylamide, and will produce a red color in reaction when a reagent is added, thus further identifying the virus as a specific species of Streptococcus pyogenes. However, to ensure that the test can be specific to Streptococcus pyogenes, first the virus must distinguish from Enterococcus prior to the test, as results can appear positive for species if not correctly specified. Through the use of these two additional diagnosis tests, in addition to the original test completed, we are confident in our diagnosis of Streptococcus pyogenes. Natural habitats, transmission and route of the infectious agent. Streptococcus pyogenes is a specific human pathogen and is most frequently found in the upper respiratory tract, found within skin and throat tissue. It allows for maximum growth and efficient transmission to new hosts. Therefore, the most common occurrence include the pharynx, rectum, vagina, and skin in both young adults and young children and old adults. These viral bacteria are highly transmissible and is most frequently spread through airborne droplets, contact with nasal secretion, or any other object contaminated with the bacteria, and can also be transmitted through dust particles. If contact is made directly to abrasions to the skin, this can lead to conditions such as cellulitis. Other lesions can be a determining factor in the cause of infection for vaginal mucosa and uterus. Prevention and treatment of infection. Common preventative practices can be used to assist in the reduction of spreading of Streptococcus viruses, including washing your hands, covering your mouth, and cleaning shared objects. All of these measures look to reduce the risk of spreading through these viruses by killing the viral bacteria that could be present on airborne droplets found within the mouth and throat of someone. Most frequently, the spread of these droplets into hands can be reduced by cleaning your hands and washing your hands sufficiently with antibacterial liquids. Important as all times, Streptococcus infections can often appear as asymptomatic, similar to coughing and sneezing, to cover one's mouth as frequently as it's spread by children within schools and other crowded areas through these nasal droplets. This will assist in avoiding skin infections to the lower limb, as eliminate the risk of the virus being spread into a portal entry, causing such an infection. Some treatment options. The most common treatment option is penicillin. Is most commonly used as a treatment for infections. Can be taken both orally and through antimicrobials. For those who are allergic to penicillin, cephalosporin may be used as a substitute. Other treatment options for severe skin infections include vancomycin and cinnamycin. Though